My name is Laura Pontrelli, and I'm doing my case study on CT angiography, pulmonary embolism using the test bolus method. So here's our patient, Mr. Quachari. He is an 87-year-old male. His symptoms include shortness of breath, chest pains, also known as angina, sweating, cough, and swelling and pain in the lower left leg. He has a family history of high cholesterol, heart attack, and blood clots. Just as a disclaimer, this is actually a photo of my grandfather that I took years prior. Previous diagnostic testing. A chest x-ray was ordered to rule out pneumonia. A calcium scoring test was ordered. He had a cardiac CT scan and blood work for cholesterol. The results of the previous testing showed that pneumonia is not visible in the lungs from the chest x-ray. His calcium score is 20, which is low. His blood work for cholesterol, both high and bad, were within the normal ranges. However, his cardiac CT with retrospective gating shows reduced cardiac output. Based on these results, more tests need to be run, and the doctor has ordered a CTA for pulmonary embolism since the patient has a history of blood clots. So protocol. So here we're using a 64 slice scanner. Our scan type is helical. Our start and end location is above the apices to below the lowest hemidiaphragm. Slice thickness is small at 1.25 millimeters with an interval of 1. Our scan field of view is large. Our display field of view is to be adjusted to the patient. Our technical factors are at 120 kV between 100 and 800 MA, or you can use Smart MA to reduce the patient's dose. Tube rotation is 0.4 seconds with a pitch ratio of 1.3 to 1. Our contrast volume is between 59 and 69 milliliters. Our flow rate is 5 milliliters per second. The direction of the scan is craniocaudal, and our prep grip delay is 6 seconds. Faster gantry rotation time allows for a higher pitch ratio, which makes the table move faster without the risk of artifact and makes the overall scan time shorter. Since the scan time is shorter, the risk of stair-step artifact as the aorta opacifies is removed, which allows us to scan craniocaudal as opposed to smart prep, which still requires the direction of the scan to be caudocranial. The test bolus method is superior to smart prep method since it is more accurately timed, which allows for shorter scan time and less overall contrast administered to the patient. So procedure. So you would select the requisition and perform hand hygiene. Call the patient from the waiting room and get the patient to spell their last name. Consent form is to be signed in the technologist's presence, and the patient should already be changed in a gown and their IV should be in. Set up the contrast protocol for test bolus, and the contrast injector should be loaded between patients. It is important to note that you must check the serum creatinine levels of the patient before you inject them with contrast. The patient should be supine on the table, feet first, with arms above their head. The next step is to communicate with your patient. So introduce yourself to the patient. Properly identify the patient to make sure that you have the correct patient. Ask for their date of birth and who the referring physician is. What tests are they there for? Have they had contrast before? Do they have allergies? Have they had diagnostic testing done before? Explain the scan procedure to them and then gain their consent to touch. Ask the patient if they have any questions and then ask them if it's okay to begin the scan. Move the patient onto the table into position. The table should move in, and using the inner center line, the zero or centering should be on the sternal notch. Zero the gantry and turn the laser lights off. Move the patient's arms above their head. Check for air inside the contrast injector tubes. Once the saline goes through the line and the air bubbles are out, the tech at the control panel should lock and arm the contrast injector. The contrast injector should be loaded, and the technician in the room can hook the patient's IV to the contrast injector and do a test injection to make sure the vessels can withstand the pressure. The technician can join their partner at the control panel, making sure the correct patient is selected. Input scout and scan should be set to feet first with centering at the sternal notch. Once this is done, we can see our scan lines and plan our scan. The scouts should start above the apices and end below the lowest hemidiaphragm. AP and lateral scouts should be taken to make sure we like our centering and aren't cutting off important anatomy. Once scouts are complete, we can put in the parameters requested on the requisition and set any recons the radiologist might need and record the contrast given to the patient. Then select SmartPrep RX to drop a monitoring line below the carina, which is at the level of the pulmonary trunk. Take one image at the monitoring line, which will give us an axial image at the pulmonary trunk. Put an ellipse ROI on the left side of the vessel without touching an edge. Once this is done, we hit monitoring phase, and then we let the patient know that we are about to inject a little bit of contrast. Make sure to move the table first, then start the scan and contrast injector at the same time. A small graph will appear on the right monitor, which will let us know when we've reached optimal opacification of the vessel, where the graph reaches its highest peak. Stop the scan when the opacification is reached and take note of how many seconds it took for the vessel to reach opacification. Jump the fence on the left monitor and add this time to the prep group delay. Click confirm at the bottom, move the table, let the patient know we're injecting the rest of the contrast. Start the scan and the rest of the contrast at the same time. The machine will automatically give the patient breathing instructions. Watch the images on the right monitor to make sure there's no artifact and that all the images and reconstructions are there. End the exam, do hand hygiene, and take the patient off the table. Get them to stay in the department for 15 minutes to make sure there's no allergic reaction to the contrast, and tell them that their doctor will get the results in 3 to 5 business days. You may dismiss the patient and clean the room. So findings. It can be clearly seen that the patient is suffering from an acute pulmonary embolism, which is seen as a filling defect in the CT image. A CT venous scan of lower extremities would commonly be performed after the CTA pulmonary embolism scan to rule out deep vein thrombosis. Here we see that in the middle image, the patient is also presenting deep vein thrombosis in the left common iliac vein and has swelling and blood clot in the popliteal vein as well. In the right image, the arrowhead is pointing to the popliteal clot and the arrows are pointing to the swelling in the patient's leg, no doubt the source of his pain. So pathology. So what exactly is a pulmonary embolism? A pulmonary embolism is simply a clot that has traveled from a deep vein, usually from the legs, that has made its way into the pulmonary arteries and is blocking flow to the lungs. In rare instances, tumors, air bubbles, amniotic fluid, or fat can be released into the vessels when a bone is broken. A person's risk of pulmonary embolism can increase if you're a smoker, are pregnant, taking birth control pills, or hormone therapy, and other factors include obesity and age. So treatment. To treat pulmonary embolisms, doctor would normally prescribe anticoagulants, aka blood thinners, to the patient to help prevent new clots from forming and old ones from getting bigger. They're usually taken for a few months. However, patients that are at a high risk for getting new blood clots might need to stay on these for the rest of their lives. If there is a life-threatening clot, thrombolytics may be used to dissolve the clot quickly or remove the clot with a minimally invasive surgery. Some patients may even need a filter to be inserted into the inferior vena cava, but there are things you can do. If you're at risk of pulmonary embolism or have had it before, the best way to prevent them is to remain active and flex the feet often if you are sitting down. Do not stay stationary after surgery. Get up and move right away. Post-processing techniques. Maximum intensity projections are used to increase the visualization of high attenuating structures. In this case, it is meant to further enhance the contrast in the pulmonary vessels to see the pulmonary embolism. Anything that doesn't have high attenuation values is discarded, leaving us only with the vessels. We can use a 3D MIP to get a 360-degree view of the heart and enhanced vessels. Whenever you're constructing a MIP, the technologist must be mindful that any calcium in the vessel can obscure the contrast. Multiplanar reformats allow you to see the anatomy in the axial, coronal, and sagittal planes. However, they cannot follow tortuous vessels as this method is 2D. Challenges. Some challenges that might occur during the scan could be motion due to the patient breathing, since they are short of breath. If there is calcium in the vessels, they could produce a beam hardening artifact, which would decrease the quality of the image or perhaps block pathologies that are present. If you don't have thin enough slices, you could get a stair-step artifact when the contrast is entering the vessels, which would also reduce image quality. Pitch needs to be at the correct level. Too fast a pitch could cause pathology to be missed. Limited detector rows can increase the scan time as well as give patients the opportunity to move and cause a motion artifact. So lab versus clinical setting. The GE16 slice scanner that is currently used in the lab is no longer used in clinical practice. The most common scanners seen in clinical practice are the 64 slice scanners. These have more detector rows, faster rotation times, different post-processing algorithms, and are able to take thinner slices, increasing the image quality of the CT scans that are performed. Faster rotation times and more detector rows can cover more anatomy per rotation, making scan times faster, which would increase productivity of the department. Conclusion. Using CTA pulmonary embolism scan protocol, Mr. Quichari has been diagnosed with a pulmonary embolism as well as deep vein thrombosis. His physician has decided to treat him using thrombolytics and he has made a full recovery. 64 slice scanners allow for better and more consistent imaging. Using the test bolus method gives more accurate imaging as well as reduces the scan time and contrast given to the patient. MIPS allow us to enhance vasculature, increasing image quality. Thank you for listening to my PowerPoint presentation.